My name is Edward Belongia. I'm the director of the Center for Clinical Epidemiology and Population Health at the Marshfield Clinic Research Institute. Well, I'm passionate about vaccines and the benefits that vaccines bring to our whole population. And I've been fortunate to be involved in vaccine research for 2 decades now, largely funded by the Centers for Disease Control and Prevention. We've been involved in studies of vaccine safety as part of the Vaccine Safety Data Link. And we're also involved in studies of vaccine effectiveness. We've done flu vaccine effectiveness since 2005. And now, of course, with COVID, we're moving into COVID vaccine effectiveness as well. So I and the people on our team, we have a tremendous team of people working on this, have a lot of experience and expertise in vaccine safety assessment, vaccine effectiveness, and immune response to vaccines. So I think we're in a good position to sort of take a look at the evidence and hopefully provide some guidance to people who are wondering whether or not this is all worth it or whether or not they should think about getting the vaccine. Of course, we heard about this last January when other parts of the world heard about it with this unusual cluster of cases in Wuhan, and watched with growing concern as it spiraled out of control in China, and then, of course, very quickly with evidence that it had escaped to multiple other countries. And so we knew what was coming down the pike. We knew it was going to get worse. I have to admit, though, that didn't think it was going to get this much worse. This is a pandemic on a scale that we have not seen since 1918. And so it is a true public health crisis, and it has required global governments and researchers and public health agencies to work together to try and address it. And we're not out of the woods yet. We still have a ways to go, but we have made tremendous progress scientifically over the past year. And now we're at the point where we have to deliver the results of that scientific advancement in terms of vaccines to the population. And we also have to clearly maintain the efforts to prevent transmission, especially with new variant viruses that are out there. And now in the United States, we have to hang in there for a few more months, but I'm confident that this will end. Things will get back to a new normal that'll be closer to what we remember as the old normal. All pandemics end, and this one is going to end. We just want it to end more quickly and with the fewest numbers of deaths and hospitalizations as possible. Vaccine development has occurred at a truly astounding pace, and I wouldn't be surprised if we see Nobel Prizes given out for some of the scientific work that formed the basis for the vaccines that we are using right now. We have 2 vaccines that have been authorized by the FDA for emergency use. I want to be clear that that's not the same as being licensed like a regular vaccine. It was done on an accelerated timeline, but no corners were cut. Scientifically, it was a rigorous process with careful review of safety data and efficacy data. The main difference is the duration of follow-up. It's normally with a licensed vaccine, we'll have a year of follow-up or more. In this case, with just several months of follow-up, then these vaccines are going to review and authorization. So we have 2 vaccines, one by Pfizer-BioNTech and the other by Moderna. And they're both called mRNA vaccines. Well, what does that mean? That really means instead of injecting a piece of the virus, which is sort of the normal vaccine approach, and then letting your body develop an immune response to that little piece of the virus. In this case, they're essentially injecting the instructions, the genetic code that tells your cells to make that piece of the virus, and then your immune system will see that and create the same response that it would get if it saw the actual virus. So it's sort of sending the software code instead of the actual protein itself. And that has a number of advantages because the code is very simple and constructing the mRNA is straightforward. and then they put it in what's called a lipid nanoparticle, which is essentially a little delivery system like a sphere that gets it into your cells. So the instructions get into your cells, and then your cells translate those instructions into the protein of the SARS-CoV-2 virus, which is called the spike protein. That's what the immune system responds to. Now, this is a process that happens in your cells all the time. It's the same process that happens if you get any kind of viral infection. The virus uses your cell's machinery, and it makes copies of itself. A key difference, though, is that the vaccines don't contain the instructions for the whole virus. You cannot get infected with this virus, and you cannot get COVID-19 from the vaccine. It is impossible. It is only sending a tiny bit of the instructions, the part that your immune system needs to see in order to develop a response. And so from that perspective, it's very elegant, and it's easy to manufacture this up to scale, because keep in mind, we need hundreds of millions of doses, and globally we need billions of doses of vaccine. And so it's very important that this is scalable and we can manufacture enough vaccine to provide the doses needed. And the RNA technology does in fact allow us to scale up and produce large numbers of doses, and also to change for new strains, for example, if we need to change the strain. That's very easily done. Compared to the old process that we use for most flu vaccines, for example, where we actually grow the virus in eggs and then we kill it and we break it up and we purify it. That's a complicated, slow process, whereas the mRNA process is much more efficient and fast. And we've discovered it's very safe as well. Side effects are things like, and these happen with multiple other vaccines as well. You may feel tired, you may feel achy, you may have a headache, you may have chills, you may have a fever. Those happen with certain vaccines. For example, the shingles vaccine causes those side effects very commonly. Well, it turns out that both of the vaccines authorized for COVID-19 also have a high rate of side effects for 1 or 2 days after being vaccinated. And this is clearly more after the second dose than after the first dose. And it tends to be more severe in younger people compared to older adults. So, and it doesn't occur in everybody. Some people may have just a little sore arm and that's about it. Other people may really feel achy and feverish for a day or two afterwards and have very low energy. It's just hard to predict. But I think the key point is that none of those are actual safety concerns. And in fact, when your immune system responds very aggressively to the vaccine, those are the sort of symptoms you expect. And so they're symptoms that should be managed, and people should be aware of the symptoms, but they don't represent any safety concern. And of course, the symptoms that you get from the vaccine is nothing compared to the damage that could be caused by actually getting COVID-19, right? So having some side effects after vaccination is a way better deal than waiting to see what happens if you get COVID-19. So that's the side effect side. We call that reactogenicity when we sort of looking at it. And that's something that is looked at very carefully because obviously we want to minimize that. But it's not a deal breaker, basically, because they're short term and they're generally mild in most people and they resolve. The other side of the coin is safety. Safety, of course, is very important. It's even more critical to make sure vaccines are safe because we give vaccines to people who are basically healthy, right? Unlike, say, medications that are given to people who are sick, they may be more willing to take some risk because they're sick and they want some benefit from that medicine. Whereas if you give a vaccine to a healthy person, the safety bar is very high. You do not want to put that person at risk at all. And so there's a long process and a rigorous process in place to evaluate the safety of these vaccines. And that begins even before clinical trials in humans with animal testing, for example. And then during the whole clinical development process, safety is a very important outcome. And they're looking for short-term and longer-term safety issues in terms of any kind of new health problems, for example, that were unexpected, that might require care. And those might occur in the first few days, the first few weeks. Generally, they almost always occur within the first 6 weeks after you get a vaccine. And so that's the time period when we're most concerned about looking at safety issues. And so as part of the requirements by the FDA for authorization of these COVID-19 vaccines, they require the manufacturers to have at least 8 weeks of safety follow-up in their study population. And these phase 3 clinical trials, which are the trials that eventually are used to justify authorization, generally enroll tens of thousands of people. And the RNA vaccines enrolled anywhere from 30 to 40,000 people in the trial. And so people who in the trial are followed for any types of adverse events for that 8-week period. And that is very carefully analyzed between the people who got the vaccine and the people who got the placebo or the saltwater injection. And they look for any imbalances. Obviously, if the vaccine is causing some problem, you expect to see it happen more often in the vaccine group compared to the placebo group. And then even after authorization, of course, the vaccine then is given to millions of people instead of thousands. And so safety monitoring is continuing right now. And now in the US, these 2 vaccines have been given to over 32 million people. There are multiple safety monitoring systems in place to look for any unexpected health problems in people who have been vaccinated. And so far, nothing has been identified that clearly links the vaccine to a new health problem. So the vaccines are extraordinarily safe, and our confidence in that is even greater now than it was at the time the FDA issued the authorization, because now we have the experience of watching it being rolled out in real time to over 32 million people and looking for any safety issues. All the data we're seeing so far shows that the vaccines are extraordinarily safe. And right now, the only serious health issue that we've seen is very rare cases of immediate allergic reactions to these vaccines. Well, an immediate allergic reaction is something we would call anaphylaxis. And that's something that most people are familiar with. If you know someone who has a severe peanut allergy, for example, I have a severe peanut allergy, so I experienced that myself. Or someone with a severe bee sting allergy, right? That's anaphylaxis. So some people can develop those types of reactions to medications or to vaccines. And these vaccines are no different. We are seeing rare occurrences of severe immediate allergic reactions, and that can involve things like shortness of breath and swelling in the throat, for example, and hives developing just minutes after vaccination. That's treatable, just like bee sting allergies are treatable, peanut allergies are treatable. It's something to be aware of and take seriously, and the CDC has put out specific recommendations for people who have a history of severe allergic reactions. And I want to also emphasize, this doesn't apply to people who have latex allergies or environmental allergies or just regular food allergies, or they might have a little rash. These are really severe, rapid allergic reactions that develop, and more like the severe peanut allergies or the severe bee sting allergies. And so people who have had a history of anaphylaxis will be watched for a longer time after they get these vaccines, but there's no reason to not get vaccinated. And the only group of people who would be recommended to avoid getting the vaccine is someone who had a severe reaction to a previous dose of that vaccine, or they have a known severe allergy to one of the components of the vaccine. Pregnancy is obviously an important consideration. And we know that during the first phase of vaccination, there were many women who were pregnant who were frontline healthcare workers. And so it's an important question, should they get the vaccine or not? And Unfortunately, we don't have a clear answer to that question at the moment. Women who were pregnant were not included in the phase 3 clinical trials, but there were women who became pregnant in the trials and they're being followed. And also, there are thousands of women who have been vaccinated now that the vaccines are being rolled out to the general population. And CDC has a registry of women who are pregnant, and they will be following them for safety outcomes. So we're going to learn a lot more about that in the coming months. But at this point, we really have to say we just don't know. Based on our experience with other vaccines, there's no reason that we would expect any particular risk or concern from being vaccinated. But really, this is an individual decision that each woman really needs to sort of assess her own risk for being exposed. We do know that COVID-19 can be more severe in women who are pregnant, and that's data that's emerging over the past few months. And so it's really a balance of the potential risk of COVID-19 and the well-known benefit of being vaccinated, but the uncertainty regarding specific studies of vaccination in pregnant women. And so it's something that each person really needs to make a personal decision in consultation with her own healthcare provider. So we have the 2 RNA vaccines that are currently available. They're highly effective, 95% protection against illness, and also appears to have a very high level of protection against severe illness, which of course is what we're most interested in, preventing hospitalization and death. It's not about preventing mild respiratory illness. So there are some disadvantages of the 2 RNA vaccines. They both need to be frozen. One of them needs to be frozen at ultra low temperatures. And that really creates some limitations in terms of distribution and providing rapid access, and especially access in areas where healthcare services are more limited. So more vaccines are coming down the pike. The next one on deck is the Johnson & Johnson vaccine. And that uses different technology. That uses what's called a viral vector approach. And essentially, it's doing the same thing insofar as it's getting your body to produce the spike protein of the coronavirus. But instead of just injecting the RNA, in this case, it's putting the gene sequence into a human virus, an adenovirus that is harmless. And that virus gets into your body and infects the cells. And then as part of the normal virus process, it produces a spike protein. A couple things about this, and I don't want to get too far down in the weeds in terms of viruses and vectors, but A, it is a harmless virus. B, it is a non-replicating virus. What does that mean? It means the virus, unlike you get the flu or something, the virus goes in, it starts making millions and billions of copies of itself in your body. This virus has been basically damaged so it can't do that. It can get into your body, and it can, one virus gets into your cell and it creates the spike protein. It doesn't make any more copies of the virus in your body. As a result, it's a very safe technology, and the same technology has been used for another licensed vaccine. So the Johnson & Johnson vaccine, which is based on this viral vector, has been submitted to the FDA for review for emergency use authorization. And I expect that review to occur later this month, and so we could be seeing this vaccine become available in March. The vaccine has around 70% protection overall, and all these vaccines appear to have a high level of protection against severe illness. So this will be a welcome addition, particularly because this is a vaccine that is stable at refrigerator temperatures, and so it's easier to handle, it's easier to store, and most importantly, it is a single-dose vaccine. And so individuals do not need to come back and get that second dose, and so we can vaccinate more people quickly. And so I think if this vaccine gets authorized and rolled out in March and April, we're going to see the vaccine supply increase quite dramatically, access be easier for people to get vaccinated. The variant strains add a degree of complexity to the whole situation. And right now there are two variant strains that are of greatest concern. One is called the UK variant. The other originated in South Africa. And I don't want to pick on those countries. It was just bad luck, right? The UK variant is in the US. Both variants are in the US now. The UK variant is spreading rapidly in the US, and the current estimate is the doubling time is around every 10 days. And so by late March, around half of the infections in the US are projected to be due to this new UK variant strain. Why is that important? Well, the UK variant strain is more easily spread from person to person. So for a given level of protection in a community overall, this strain is going to create more infections than the original strain. So it means we need to be even more adherent to the masking and the social distancing. Those things work. It's just that we have to do them more rigorously because this virus gets around them. If you're not strictly adherent to those recommendations, there's a greater chance that transmission will occur with the UK variant. That's the bad news. The good news is it looks like the Moderna vaccine, the Pfizer vaccine, generate strong antibody response to the UK variant and likely will provide a high level of protection against it. Similarly with the Johnson & Johnson vaccine. So that's good news. The South Africa variant is a little more concerning in the sense that we are seeing evidence that some of these vaccines do not generate the level of protection against the South Africa strain that they do to the original strain. And in particular, it's just been news recently, a vaccine we haven't talked about, the AstraZeneca vaccine that is currently being used in some other parts of the world, but not in the US, provided a very low level of protection against the South Africa variant. Other vaccines have somewhat reduced protection against symptomatic illness with the South Africa strain, but there is some protection. And again, very importantly, I think there's a great hope that we'll still see a high level of protection against hospitalization and severe illness. So there's a lot to be learned about vaccine protection against the South Africa strain. There are some concerns out there, some red flags. And I know that some of the manufacturers are already working on developing a booster that is specifically designed for that strain. And so we may end up seeing that in the future, depending on how things go and what level of protection we actually see. I think a key message, though, right now with the UK strain spreading in the United States is that really it's a race now to get people vaccinated as quickly as we can and get a high level of vaccine coverage before we see more widespread transmission of these strains. And so widespread vaccination is really the key. The other key, obviously, is the importance of masking and social distancing and avoiding indoor gatherings. We can't let up on those things. We have to continue on that until we reach enough vaccine coverage that we're getting herd immunity. There's some evidence that is, at this point, I think very preliminary as to whether or not they might cause more severe illness, more hospitalizations. But in general, the symptoms, the type of illness you would get would be no different. There's no way you can tell these strains apart based on the type of illness you get. And in fact, what is needed is what's called genomic surveillance. Essentially, we have to get samples of the virus from all over the United States and determine the sequence of the genes in the virus. And it's only through doing genomic surveillance around the country and sequencing these viruses that we can really determine how severe the problem is and where the problem is. Of course, that will help us in terms of determining how well the vaccine is protecting against these variant strains. So a lot to be learned about the variant strains. We're really just at the beginning of this process. Ultimately, it could become a lot more like the flu vaccine, where the flu vaccine gets updated every year. We have new strains being put in to the flu vaccine, and I think there's a very good chance that we'll end up in a similar situation with COVID-19 vaccines, where there'll be periodic strain updates, and we will very likely get to the point where we maybe have a vaccine that has multiple different strains in it, like the flu vaccine currently does. I think another a point or question that we get frequently is which vaccine should I get? And the answer to that is really simple. Get whatever vaccine is offered to you when you're eligible to get one. These vaccines are all highly effective. The differences between them are not important from any meaningful perspective. And so the most important thing is to get vaccinated as quickly as you can. And from a society perspective, the goal is to get as many people vaccinated in this country as quickly as we can. And it doesn't matter which vaccine you get. If you're getting a vaccine, you can be very confident that it has undergone a rigorous review for both safety and effectiveness, not only by the FDA, but also by independent advisory panels from the FDA and the CDC. So people, I think, should have a high degree of trust that these vaccines have really been very carefully vetted. And if they're being offered, it's because we have very strong and convincing evidence for their safety and their effectiveness. People with serious chronic diseases should get the vaccine just as quickly as they can. And I know it's been tough, and I've heard from people who have those conditions and want to get the vaccine, and because of the limited supply, they have not been able to get it yet. And I know that's very frustrating. There may be other people who are wondering if they should get it, and I would really want to encourage everyone to get it, especially people who have serious chronic diseases, because we know for sure that people with diabetes or kidney disease or heart disease have an increased risk of having a severe COVID-19 illness and a higher risk of being hospitalized or dying. And so those folks were all included in the clinical trials. And so we have safety data, we have effectiveness data, and they're included under the FDA authorization. So clearly, I think they're a priority group, and encourage them to get vaccinated just as soon as the supply allows that to happen. Yeah, there's been a lot of discussion about the situation with people who have previously had COVID and whether or not they should get the vaccine. And we are learning that COVID infection does give you some protection for at least several months after your infection. But we don't really know the strength of that protection, and we don't know how long it lasts. And so we know a lot more about the protection offered by the vaccines. And so the current recommendation is that people who have had COVID should get vaccinated. However, because of the fact that there's currently a shortage of vaccine supply, the demand is much greater than the supply. And because we know that people who previously have had COVID do have some level of protection for a few months, it is reasonable for someone to defer vaccination if they want to for a few months after having had COVID, so that those doses can be made available to other people who don't have any protection. But ultimately, everybody should be vaccinated, including people who have previously had COVID. There's also been some debate and discussion in the media about, well, do they only need one dose? Should they get 2 doses? And the CDC recommendation, which I think is clearly based on the science, is that we know a lot about 2 doses. We know 2 doses provide a very high level of protection. We know much less about a single dose protection and the duration of that protection. And so I think the recommendation, which is a good one, is based on the science, which is a 2-dose series. And I'm very confident that over the next 1 to 2 months, especially if we get the Johnson & Johnson vaccine authorized, we're going to see a real ramp up of the vaccine supply, and people are going to have a lot more access to vaccine. Whereas right now, I know it's been frustrating and slow, but I think we're almost at the end of that, and it's going to get a lot better in the near future.